Well, we're going to talk about therapy. The objective, some biomedical therapies. Remember him? I don't remember his name. Was it Bob? Some of you can remember. It's been a while now. That's, yeah, both schizophrenics right there. Bob living in his home. Jerry, paranoid and delusional, living in a kind of in a ward. I don't remember her name. Anybody? Anyway, I don't remember. But now, she was the one that would wash her hands and see her son and be afraid of that someone was going to snatch him or he'd get disordered. We just saw Mary, and briefly last time we talked a little bit about someone who also had some manic symptoms. So the question is going to be, psychotherapy or psychological treatment is necessary for these individuals. And the definition of what psychotherapy is this emotionally charged, what we call confiding interaction. And this confiding interaction is taking place between somebody who's clearly hurting and suffering and somebody who is trained to deal with that particular disorder. And that's what psychotherapy is. It's an emotionally charged interaction in which people can then talk with somebody who's trained in a particular area to bring help to someone who suffers from one of these difficulties. That's what we're going to talk about. So, let me start with just a broad overview of psychotherapy and some of the objectives that people will attempt in bringing relief to individuals like this. Most of the time, people who are interested in going into the field of clinical psychology can deal with major psychological disorders like some of these we've been talking about, and their training is, I want to help them. So this Thanksgiving, it's late at night, and I'm driving down the street, coming home from a Thanksgiving meal with family, and there's a girl on the side of the road. And she waves me down, and so my wife and I were in the car, clearly suffering from some sort of disorder, and probably had alcohol involved in this as well. But we were watching her, so we pulled over and gave her some help, and about an hour and a half later, one of the things we ended up doing was getting her to a place where she was safe, providing something like what we almost like first aid to somebody. But it was clear that she was dealing with some difficulties, and that made life hard. She wasn't making the right choices. She was, again, clearly in trauma, but it wasn't so much so that she would be need to go to a therapist right then, or maybe even need to go to a hospital, but she was borderline. What was one thing we could have done if we saw her and we were concerned, thinking that she couldn't take care of herself? Well, one thing is many people just say, well, let's just call the police. And police will come out and they'll do an evaluation. What will they call it if they see someone suffering from a disorder like that who can't take care of themselves? Anybody know even the number that they'll use? Unstable? Okay, yeah. So so they'll diagnose them as being unstable or unable to take care of themselves, or that maybe they're a harm to somebody. But what are the police going to do at that point? Well, remember we talked about this, that for someone suffering from a disorder like this, they'll use what's called 5150, right? You've heard of that before? In California Penal Code policy, it's someone who is clearly unable to help themselves. So this person that we talked with and that we helped that night, it was hard to know what to do. I think for most people, when they encounter somebody dealing with one of these emotional or psychological or even physical difficulties, it becomes hard to know, how do I help this person? Some of you have a suite mate or someone on the floor or a friend that you're like, gosh, I don't know what to do with that. I don't know how to help. And this is where it becomes very difficult. And this is why there are people who are trained, who have gone into this field and who said, this is what I want to do. This is how I want to help. So it's, by the way, why I started working with and did an internship with schizophrenics, those on this maximum security ward, because it was for me an opportunity to see what can I do, how can I provide help, and what can I get training in. And it's hard work. The reason it's hard work is partially because of a number like this. Most of the time, people that suffer from a mental illness like this deny that they're sick. And that makes it difficult. So when you're talking to somebody, so this person on Thanksgiving night, it was hard for this person to even admit they were suffering from something when clearly they were in need. One possibility would have been an involuntary hospitalization of this person. It came very close for me to call and see it, and the police would have come and they probably would have seen this person, and no doubt would have used what's called the California Welfare Institutional Code Section 5150 on her and involuntarily hospitalized her. That's a common practice every day for our police officers and those law enforcement officers that get called out. When someone is clearly not functioning well, they will hold a person for 72 hours, and this varies by states and by countries. In this particular state that we're in, you can hold somebody involuntarily for 72 hours if you're worried about them. Now this person, we took away their keys and actually got her a place to stay and told her in the morning she can get her keys because we thought maybe, we weren't sure what she was on. We thought that would help. But if that isn't the case, then if after a couple of days a person doesn't get better, they can be held with authorities petitioning for up to 14 days in California. So in most mental institutions around here that take in individuals, you could go in and get a 72-hour stay. Most of you can go into a 72-hour stay. In fact, a common way that a sign that they look for is someone who is in trauma, or if you were to walk up to any local institution and truly be hearing voices and said that, I hear voices, you'll probably get a 72-hour stay. If you need a place to stay some weekend, you're going to get hot meals and you're going to get a place, you're going to get people evaluating you, because in this culture we tend not to say that people who hear voices in this culture we're a little suspicious of. And it's the sad reality that in some places the person is left with, gosh, I don't know how to, but they will try and make a decision. When should we involuntarily hospitalize somebody? And this will happen. So, by the way, just in this county alone, they get 20 to 25 calls every day that result in involuntary hospitalizations. Somebody's not functioning well, whether they're hearing voices or whether they're a danger to themselves. And you can just put up the latest person that you've seen in the news. There are a lot of actors and actresses that get called on every day, mostly probably because of certain disorders or drug use or whatever, and we can hospitalize them. Now, by the way, after that 72-hour period, if the person wants to leave, most likely they're going to be able to leave. And then on this one, as far as ultimately when people do admit it and they go seek help, it's the full gamut from children all the way to older adults. And I mean, you don't have to write all of these down. In fact, I'll just show you, these are the common ages and the disorders or the type of therapy or type of thing that they're seeking help from. When a child tends to show up in a therapist's office, it's usually some sort of developmental disorder, autism, ADHD, things like that. In college students, it's probably most common to deal with anxiety or depression, marital therapy, and then grief therapy. So just as an example, this runs the full gamut of ages. And there are people who specialize in each of these ages and of each of these disorders. Okay? All right, questions. I want to show you real quickly, we're going to take some of the disorders we've seen and apply and show you some therapy sessions. Bottom line, ready? The objective of all therapies. People that decide, I want to go into this field, I just want to help someone who struggles like this. I want to be able to provide help, provide aid, provide hope. And that's probably one of the main objectives, is providing hope for the people that are demoralized. And then in that, helping them get and receive a new perspective on life in a relationship in which there's trust and empathy. And that would be the objective for almost all therapies out there, to help a person get better, help them grow, and help them find satisfaction with their life and their circumstances. All right, general questions about therapy. I'm going to show you specifics now and some therapy session with a couple of people and what it looks like. Are there any questions about therapy in general? Things you've heard about, things you've wondered about? Nothing? All right. So these are ways and things that most people struggle with. Yeah, sorry, did I miss you the first time?
Is there a difference between counseling and therapy?
No, it's a great question. I'm using the word interchangeably. He asked, is there a difference between counseling and therapy? We use them pretty interchangeably. So a counselor could be, you could refer to someone as a therapist or a counselor. And usually somebody that's licensed is always going to have at least a master's degree and report to somebody with a doctorate, whether it's a doctorate in counseling or in clinical psychology, or someone with a master's level degree that ended in like a terminal degree, like someone with MFCC degree. But some of them call themselves counselors, some therapists, and but anybody could use the phrase psychotherapist, and so you have to be real careful with that one. But yeah, no, about the same, about interchangeable. All right, and in fact, you could see the difference would be here, a counselor, clinical psychologists and psychiatrists, you start with this college degree and then you can go and specialize. Some people who go into counseling want to go and work probably with maybe not as major of disorders, and they tend to go into counseling psych. Some who go and work in a clinical, with a clinical PhD tend to work with a little bit more severe clients, like the ones we've been seeing in here. And then some could go and work in a medical field and do a medical doctorate with a psychiatry residency. All right, so biomedical is a big area. The use of drugs to help people. This person that I picked, we helped that night on Thanksgiving, clearly was under drug treatment and was probably even abusing some of that. But it's just fairly common for some therapies to rely on this biomedical approach, which is extremely helpful. Bottom line, ready? Biomedical treatments for some disorders is a lifesaver for a lot of people. It's a blessing in their life because it brings them back from deep, deep despair and deep feelings of anxiety. And so some people, when they go and they receive drug therapy, is very helpful, very needed. And under the right doctors and working with them, it just brings relief to a lot of people. And it can be just a remarkable turn for some. And there's also kind of some criticisms that we're using drug therapies too much or too readily or too quickly. And I think there's some corrections that are going on, and we always have to be real careful for this and of this. If you tend to go into drug treatment, it's going to be usually in the area of 3 categories. The anti-anxieties, the antipsychotics that can cover a whole different range. So Valium and Xanax for anti-anxiety. This person that I told you about, she was on doses of Xanax and was unfortunately using alcohol at the same time, so that probably was causing some of her problems and issues. The antipsychotics, Thorazine and Haldol, and there's just a ton. I could put it, like, I'll just show you all these different medications that are used for antipsychotics, and there's just more and more being discovered that bring help to people. And then there's a whole bunch of the antidepressants. You're probably familiar with some of these, Zolofts and Prozacs and Paxils, and those are the categories, the main categories for drug therapy. One more time, this can be life-changing for people. Very helpful for those who are suffering from these, and there's also some side effects for some people that are hard to navigate and manage. And that's why there's so many of these drugs, because they each have different kinds of side effects. Some help some people, while others don't seem to help at all. All right, drug therapies, drug treatments. By the way, there's one other category real quickly, and that's lithium for bipolar mood disorders. It doesn't kind of fall neatly into one of these three categories, but lithium is fairly common for those who are suffering from a bipolar disorder. And by the way, bipolar drug treatments are very effective in helping people who are going like that, up and down. High levels of mania and low, and then the depths of depression, lithium seems to help. It's a big, big business. And when that happens, the biggest criticism is we rely too strongly on medication. It's almost like people rely. You go in and you talk to a doctor, your general practitioner. If you were to tell them you have anxiety or feelings of anxiousness, you're probably going to walk away that day with the prescription for an anti-anxiety. It's just simply easier sometimes, and so medical doctors will oftentimes overprescribe, but that's one of the biggest criticisms is overprescribing. If for something like depression, like you saw Mary, ready? Guess what? Antidepressants didn't help her. We could put antidepressants in here. How many know somebody who's taking an antidepressant and it doesn't help them? They stay that way. This is a very hard place to get. Ready? If someone suffers from depression like Mary, you're going to start with therapy. You're going to start with what's called psychopharmacotherapy, which is psychological, and drugs. But for Mary, it didn't help. Drugs will just go on and on. So the next step is something called electroconvulsive therapy. How many have ever heard of electroconvulsive therapy? It's called shock therapy, ECT. And basically what you do is you take someone with depression, and they used this originally back in the 50s, maybe in the 40s. There was a person who believed incorrectly that, that people who had schizophrenia did not suffer from some of the seizures that were associated with epilepsy. And so they thought, okay, we don't find schizophrenics with epilepsy. So one thing is maybe they don't coexist together. So if we put somebody into a seizure, maybe it'll help their schizophrenia. And that's what they thought. So guess what they would do? Anybody seen One Flew Over the Cuckoo's Nest, the movie with Jack Nicholson years and years ago? It's a very old movie. It was a way of taking people who are institutionalized, suffering from things like schizophrenia, who would also act out. They would put them and shock them such that they would experience a seizure, in the hope that it would, first of all, that they would stop having schizophrenic symptoms. It didn't work, but it did, quote, calm the people down because they were shocked and put into seizure, and their whole brain kind of went like that for this brief period of time, is fairly violent. And then they used it almost like a discipline thing. But one consequence was, ready? If a person was misdiagnosed and had depression, and they had gotten the electroconvulsive therapy, their depression went away. And today, this is one of the most common treatments for major depression when medication doesn't work. So here's Mary, whose medication didn't work. She took a couple of different rounds of electroconvulsive therapy. And this is her during it and then after.
ECT is a powerful way to treat severe depression, but it is used only when traditional medication approaches have failed.
Just look at me.
What about you that's different?
Everything. I smell.
You have a body odor?
Mm-hmm. My hair's falling out.
Hmm?
I'm disgusting. I'm evil.
In fact, you think that you should be dead. Did you try to kill yourself? Did you really?
Yep.
Tell me about it.
Took a bunch of pills, aspirin,
When was this?
on Thanksgiving.
When Mary attempted suicide,
Morning, afternoon.
it opened all her feelings to the world. They now were expressed in all their intensity. She was worthless, hopeless, life was not worth living. She felt she was the devil, and she had the idea that the only way to end this terrible pain was suicide. She tried at home. Her husband brought her right to the hospital, and from that moment on, she had to be monitored. We had to have an individual sit with her 24 hours a day, because all she could think of was trying to kill herself. There were hours in the next few days that we had to put Mary into restraints. The alternative was that she would scream and try to kill herself by any device possible. It became necessary to treat her as rapidly and as effectively as we knew how for this drive to suicide and this very severe feeling of unhappiness.
This is what it looks like when you get electroconvulsive therapy.
At the beginning of ECT treatment, the patient is put to sleep, and 30 seconds later is given a dose of muscle relaxant.
Brevitol's going in.
Nice deep breath. You'll be fine by the end.
The lid reflex is gone.
Cuff is up.
Okay. The bite block is in.
Chin up.
The impedance is low. Okay.
At that point, electric current is passed through the brain for a duration of half a second to 4 seconds. Typically, 6 to 10 treatments, spaced over 2 to 3 weeks, will be given. ECT produces a seizure, which needs to last for 25 to 120 seconds to be a good or effective treatment. After ECT treatments, patients will show confusion and loss of memory for recent experiences. Both of these problems clear up, and permanent memory problems after ECT are rare.
Mary, open your eyes. Treatment's all over with.
In Mary's case, medication did not help, and so electroconvulsive therapy was the best alternative. After treatment, Mary discussed her recent depression with her doctor.
The depression that I came in here with, I don't really remember much about.
Remember nothing about it.
Mm-mm. I do remember going home being in the hospital here and going home on Thanksgiving and taking a lot of aspirin. I remember that.
What happened on Thanksgiving?
I remember thinking I was the devil
Yeah.
and taking aspirin, and then my son coming from my neighbor's house and coming into the bedroom, and then I remember feeling bad that I had done that because I didn't want to die and leave him. And then I told him to go tell his father that I had taken a bottle of aspirin. And then
So what do you think? She look different? Freaky, huh? they'll go on and talk a little bit. It's not a panacea. It's not a cure-all. You can't just give everybody with depression, ECT. But more and more, the numbers are showing they went down for a while, then they started increasing, and now with technology and putting her to sleep, she doesn't really feel this. It's increasing. It's probably doubled that number over the last few years. Mary will have to go in. She'll have to go in a couple of times. She probably went in for I don't know how many treatments over a couple of week period to get to that point. And but you could see something happened during that controlled seizure time that took care of depression, which is, by the way, one of the big mysteries. No one really knows why someone who has a seizure or why they stop feeling depressed symptoms like that. And that's the weird part. There isn't really a kind of like, oh, this is what's happening in the brain. When you have a seizure, it does this. We just don't know what's happening. All we know is you see Mary before and then Mary after, and you realize something has happened there that has done something, and it's very powerful for those in which drugs seem to not hit the depression. But there is no good answer to the question of how does it work, because no one's really sure. All right, so that's ECT. That's called electroconvulsive therapy, shock therapy. I used to have a joke back in the 60s and 70s and even the 80s when people would say they're about to go see the Colonel, they would say, because they're about to get fried. Kentucky Fried Chicken. I'm about to go get fried. I'm going to go see the Colonel. And it wasn't always it was like this weird thing. Today, like I said, it's more commonly done for major depression. So that's ECT, electroconvulsive therapy. There's a lot of drug treatments going on there. This person's daily rating of depression goes down significantly from the high, let's say 10 to 12 to 14 is the highest levels of depression that you can feel. And then after ECT, you can see over a few weeks, individuals that suffer from depression, their numbers are just way down to what's called normal levels. All right, questions? Anything else? Yeah?
What would happen if a person who didn't suffer from depression or any psychological disorder, if they were given
Yeah. Yeah, electroconvulsive therapy. If there, my guess is there would probably be no additional, symptoms. If a person who is completely normal underwent electroconvulsive therapy, my guess is the same thing that would happen to someone who's depressed. They would probably come out feeling about the same, not probably any different, but there are some memory problems short term, right before and after treatment. They kind of forget a lot of that. They may not really remember that. Kind of like being in an accident sometimes, the brain doesn't hold on to memories during there. And so, but that would be the symptoms and the consequences of ECT. That's probably all that would happen. Yeah, interesting question though. All right. Okay, anything else? The treatment that goes on with some individuals, I'm going to show you now the person who did her hand washing and some of the psychological treatment, and she's doing both medical and psychological. And you're going to see here, she's taking medication, ready, to help her anxiety. This is the one who thought her kid was being, looked upon or was going to have germs, and so she would wash her hands all the time. She is definitely taking medication, and you're going to see some of the psychological therapy that will help her. They're going to try and get her, for example, she thinks everything that anybody touches is dirty, so now they're going to try and help her, for example, bring the mail into the house. And that was a big success if she can do that, because she is afraid her kid will get sick. So we'll show you, you'll remember her in just a second, what's called exposure and response prevention to help treat obsessive compulsive disorder.
Stephanie's fear of contamination has colonized every aspect of her life. Her whole house is subject to a decontamination ritual as strict as the one she uses on herself.
I have to clean in a certain way, and I start at the front door and I work backward. Once I start cleaning, I can't stop. And I have to decontaminate in the perfect way, like nothing can go wrong. If it does, the contamination jumps to something else. It's really frightening when something gets contaminated because you know it's only a matter of time before it takes over everything.
Stephanie's starting her therapy. She's been taking Prozac, which often helps OCD, but it hasn't been enough. Dr. Yadin has come to begin cognitive behavioural therapy. Today, Stephanie's going to bring in the mail, which she hasn't done for a year.
Okay. So how nervous is this making you? Give me a number.
Just so you know what you're about to see, this would be, she's taken Prozac, so this is a combination of drug therapy. And now this part of therapy, the therapist here is going to do something called cognitive behavioral therapy, helping her rethink or think through and why she thinks there's germs on this and what to do with those thoughts. So that's kind of an example that is brought out in this clip.
It's 40 right now. 40 right now? That's
Maybe
good.
30, it's okay.
It's low? Good,
Yeah.
excellent.
It makes me nervous to put it down. I don't want to put it down anywhere.
Okay, I will help you.
For Stephanie, who has a terror of contamination from bodily fluids, the thought of handling envelopes, which someone might have licked shut, is particularly repugnant.
Is recognizable.
The idea is to expose Stephanie to situations that cause her anxiety, but then prevent her from doing the compulsive cleaning rituals she normally would do to contain it.
40, maybe.
40.
Getting up at 40.
Okay, good, good. Just go for it. Just pounce on it. Don't be too careful. Good, excellent. All right, and now that you've done this, your hands are contaminated. Is it?
It's difficult.
Is it difficult? How difficult, Stephanie?
50.
At 50? That's okay. You can tolerate it. It's all right. Remember, I told you it's going to be very difficult for you. Okay? What could you touch? I mean, touching Jake would be too hard for you right now, would it? Okay, what can you touch that's not that hard? Your
The
hair?
couch.
The couch? You could touch the couch?
The back of the couch.
Okay, so let's do that. Ready? Good. And when you do exposures, I would like you to touch the couch everywhere.
Oh, okay.
Okay, I know it's hard for you. Okay. Can I do something to help with the anxiety?
Can you touch the couch first?
Yes, absolutely. I want you to touch it like this, okay?
Okay.
Stephanie's
Both hands
contaminated
on
her
both
hands, and now Dr.
Nothing
Yadin
is-
wants her to spread
Okay,
the
good.
contamination around.
Now that's very difficult for you, but you're able to do it.
It's better.
It is better already?
Yeah.
Good. You know, the anticipation usually makes it worse.
Yeah.
So you want to pounce on it as fast as you can. So you see what happens is, and the reason it's called exposures, is it's the things you've been avoiding and you don't get a chance to test. You were very courageous already. You might as well capitalize on it.
Stephanie has to spread the alien germs she imagines are on the letter all over the couch.
I'm going to move so that you can do it.
Infecting the couch is one thing, but can Stephanie go one stage further and expose her son Jake to the germs?
Good. I like the energy that you're showing going towards...
I'm angry at it.
You angry at the OCD?
Yeah.
Good. I like that. I want you to be angry at the OCD, not at yourself.
Yeah.
Okay? I'm angry at your OCD too. It's ruining your life.
Yeah.
I want us both to be able to...
I can
come
handle
to a point.
Jake.
You can?
Yeah, I can.
Let's do it.
Come here, honey. Oh, well, maybe not.
Why?
Are you sure it's okay?
It's wonderful.
You sure it's
It is
all right to do
okay.
it?
It's okay to do it. Yes, I'm positive.
It won't
it's
harm
okay.
him.
When we go to the higher items, I won't reassure you, but for the first time, absolutely.
Put him on the couch.
Good, good.
Put him on the couch.
Yeah. Just hold him for a little while. Yeah, just hold him for a little while. Hi, Mommy. Hi, Mommy. How anxious
It's
are
okay,
you?
though. It's okay to put him on the couch.
It is okay to put him on the couch. It is. Because remember, you just touched, and you...
Okay.
And we're just doing an exposure, and
It's not, I'm not a bad mother if I do that.
You're asking me for reassurance?
Okay.
You're okay? Hi, Jake. He doesn't know me very well. Good. All right. How does it feel? What are your suds? How nervous?
60.
75% of people with OCD show some improvement with cognitive behavioral therapy.
Yes.
Our experience with other people who have this kind of OCD are that many of them will get a lot better by the end of treatment.
No, it's making me feel free.
Stephanie has been through 9 sessions of her therapy now.
I'm well on my way to life again, and have made incredible progress in many small ways.
One of the most important things is that she can now let Jake pick things off the ground and behave like a normal child while she behaves like a normal mother.
I've been able to reorganize in my mind what is something to be fearful of and what is not. Jake and I are a team, and we're out there discovering together. Because for a year, I stopped experiencing things and looking at things.
Bark. Gotta look for more of those, see if you see any. See if you find any.
Something that I never would have been able to do before, I can do without even thinking about it.
Oops. All right,
I can let spontaneous things happen. You can call that a cure, but the OCD's not gone. The obsessions, gosh, the obsessions maybe are gone. Compulsions are, no, the obsessions are maybe still there. I don't know. It's hard to say when you become, who is normal anyway?
Yeah, who is normal? That's a pretty cool little outcome. She had up to what? How many sessions? 9. She's taken Prozac, and that's what you do. You combine the psychological or what's called talking therapies with this biomedical drug treatments, and it doesn't always happen that quickly or that easily. But is her name Sarah? Is that what it was? Yes. Sarah? Stephanie. In that with Stephanie, what ended up happening is, again, a kind of a positive outcome. Probably just the drugs wouldn't have helped her with her thinking, and that's what that therapy session was about. She thought that germs were getting spread everywhere, and it was the anticipation of it being everywhere, and that she just she didn't want to do it. And so what this treatment was to expose her to that, to say, listen, we're going to show you that this isn't that bad. And so that kind of therapy is a very unique, special kind of therapy, but it is one of the talking therapies, or what we call psychological therapies, that's done. Any questions about that with Mary? And I think this is why you could see for her, Mary, afterwards, she looked more hopeful, didn't she? She wasn't demoralized. To watch that little baby of hers, Jake, pick things up, just 9 weeks before that, or however long before that, you could see there is no way she could have done that. To run around like that. So I think that's why we know there's help for people. And sometimes people with obsessive compulsive disorders or depression, they don't show up. They even deny they're sick, and then so I think people who get into this area of help and treatment see these successes and go, okay, I want to bring and help others. Questions about that? Anything related to this that would be helpful, or things that you want to know about? All right. Psychotherapy. Most psychotherapists don't use the specific type of therapy only. They use a variety of therapies, or what we call an eclectic approach. They kind of, sometimes with someone who they might see that suffers from OCD, they might use some cognitive behavioral approaches like exposure therapy. But sometimes they might use some other method from a different type of therapy or a different theoretical school and use that in treating somebody. And so most, I think, psychologists that specialize in this area or psychotherapists would probably call themselves eclectic. Some specialize and that's all they see. Kind of like a medical doctor only sees people, you know, with a certain kind of heart disease and they're that specialized. But more like a general practitioners would be most psychologists. They kind of use different methods depending upon what the person is or the client might be struggling with. Okay? So when you hear someone's a psychotherapist, it probably means they use a variety of different practices. I'll put that slide back up, but you saw one in kind of a cognitive or behavioral approach, psychodynamic, but the vast majority would be eclectic, what we call from an eclectic approach. And then, of course, not everybody needs to go to a psychotherapist for some of the things they might struggle with, and so people are able to find help, especially with those less severe disorders, in areas that, you know, could be, you know, pretty high up there in the area of counseling, psych, but even other kinds like support groups, even biblical counseling or Alcoholics Anonymous. Those are also ways in which people are able to get help from you know, certain kinds of disorders they may be struggling with. Usually the more severe, the more likely you are to find the need to see someone who has a license and who's trained. But people can find help with a variety of sources in other areas as well. Some alternatives that way. All right. Any other questions about psychological therapies? By the way, I'm going to give you the task of reading about 4 of them in your textbook. It talks about different types of psychological therapies, and it lists the 4 major psychological therapies in there. And so in that regard, look up in the textbook and look at the 4 major psychological therapies that are out there. And the book lists those from psychoanalysis to person-centered, to behavioral, and to some cognitive therapies. And those are the most, I guess you'd call the most dominant, but there are a variety of other types that could be out there, and your book lists those. So read up on those. Are there any questions about psychological therapies, questions that you have? Because otherwise, we get out a little bit early.
Biola University offers a variety of biblically centered degree programs, ranging from business to ministry to the arts and sciences. Visit biola.edu to find out how Biola could make a difference in your life.